Welcome to episode 4 of Speaking of Women's Health, our podcast about the Women's Health Programme that we ran in Dorset last year. And I'm really happy to be here today with my delicious co-host, Anjali. Hi, Anjali.
Hello, Marian. How are you doing?
I'm doing very well today, thank you. It's a bit of a dreary day outside, but we're here talking women's health, which always makes me happy.
Yeah, same here. So glad we are again back on action.
And today's episode is about women who come from minority backgrounds.
And it's me.
That's you. You count yourself as one of those, Angie. Maybe we'll get into that in a minute. Because what we found in this women's health programme was that what came up again and again and again was the inequality experienced by women from minority backgrounds. And when I say that, what do I mean by women from minority backgrounds? I mean women from an ethnic minority background. And in Dorset, actually, our biggest ethnic minority is women from Gypsy and Traveller communities. And then we've got all sorts of a wonderful, rich, diverse range of other people from ethnic groups, which you can talk about far more eloquently than me, Anjali. But we're also talking about women who have disability, older women, younger women, anyone who really just doesn't fit into that majority of the kind of middle-aged general kind of white woman profile that Dorset has so many of. So that's what we were talking about today, because there are some really shocking statistics. So, Anjali, you've already said you call yourself a woman from an ethnic minority. Tell us more about that. How does all of this resonate with you?
Well, each episode has a lot of information and meaning detailing, but this episode is definitely one of the very close to me because I am from this background, and I can say there's, because of a lot of lack of information and support within the medical sector, we really get lost. So talking to the specialist today, I think it's very important for me to raise the question how we can get involved, why we are not giving the equal opportunities, especially not only ethnic background, the disabled women in ethnic background, that also very important because of the myth we came, the different cultural background we have. So I think this is very important to understand why there is a gap and why we are not giving a full information on time.
And I know in this episode, Lorraine talks very passionately about the ability for disabled women to actually get in and have some of these services that are available for women. But she's had personal experience, but I know she's a huge champion for other women who have similar. So, it's such an important topic. And I'm just so glad you're here.
I can share personal experience, personal stories, because I have many stories to talk about.
Yeah. It must be so frustrating for you.
It is indeed. And me being a person who knows the system because of my personal experience, I start working on it. But there are many women who come with hope. I can help them. I think this episode will give them more hope and information to carry forward. So very important. I'm excited for myself, but for more about people I'm working who are lost in the system.
Yeah, well, that's fantastic. So let's crack on and hear what our fabulous guests have to say this week and reassure people that there are people like them out there really trying to do something about it. We are really excited today to be doing this podcast about more minority women's voices when it comes to women's health. And I'm so pleased to have with us today Linda from Bournemouth University and Lorraine from an organisation called SWAD. They will both do much better jobs than me at telling you who they are. So, Linda, why don't you tell us who you are, what you do, and where you're from? That sounds like something out of Blind Date.
My name is Linda Agyemang. I'm a senior lecturer in adult nursing at Bournemouth University, and I've been so passionate about women's health, particularly around Black women and their health around cancer inequalities.
Amazing work that you do, Linda. I know I've heard lots about the amazing things you're working on. Maybe we'll talk about them a bit more as we go through. Lorraine, do you want to tell us who you are?
Yeah, I'm Lorraine Stanley, and I'm the founder and CEO of SWAD, SWAD, which stands for Sex with a Difference. We're a not-for-profit training organisation specialising in the area of disability and sex. And I also do a lot of work around women's health inequalities. Interestingly, also in a lot of ways related to cancer screening. So I think this could be quite a juicy episode, really.
Well, interestingly enough, correct me if I'm wrong, Anjali, but all the other episodes we've recorded so far, the inequality for the needs of women from any kind of minority background, whether it's an ethnic minority or kind of economic minority, it's come up every time, hasn't it, Anjali, in terms of how important that inequality is and how it affects people's access to health care. So I am also hoping this will be a very juicy episode, Lorraine. Anjali, do you want to just introduce who you are, given that you've not met these two before, which I thought you must have done. So just give us a bit of background about who you are.
Yeah. Hi, everyone. My name is Anjali Mavi, and I'm a radio presenter, and I work in the community. I'm founder of BPC Indian Community, which is Bournemouth, Poole, Christchurch, and here in Southampton also. I represent Indian community, but I work with many diverse community. I work with NHS also. But right now, my focus is working with Dorset women and talk about this amazing project they have done. And I'm co-hosting with Lorraine.
Yes, so Anjali brings a brilliant perspective to all of this, having lived experience of many of the inequalities that we talk about, which is great. So let's kick off with quite a general question, which I want to put to you both, about why do you think, or why is it important that talking about the views, needs and inequalities for women from minority backgrounds is important at all? I hesitate to say in the current climate, but you kind of read that between the lines. Why is it important to have this conversation? Linda, do you want to start?
It is very important that we continue to talk about it because we are continuously seeing the inequalities being faced by marginalized women. For example, we heard about the Embrace report that highlighted the inequalities in maternity care faced by Black women. So these issues continue to widen. We also saw reports from LIMB, et al., on breast cancer inequalities that are faced by Black women. So all these issues around cancer and also on maternity, and these are not the only issues. We know about other long-term health conditions that women, particularly from minority backgrounds, continue to face. So it means that these issues or these concerns continue to exist. So we need to talk about it so that if we are not talking about it, then there's no opportunity to then do something about it or even to reflect on whether what we are doing now is actually working or not. So I think it's important that we talk about it.
And I don't want to put you on the spot, Linda, but you mentioned two reports. So it'd be really good for our listeners who haven't heard of those reports, perhaps that we could put a link. So if you could share those at some point, that would be amazing. The Embrace report you talked about. Can you give us a couple of examples of the kind of things that those reports highlighted?
So the Embrace report was published when we heard about the maternity cases in terms of Black women who are about 4 times likely to die. We also know from LIMB study that highlighted how the likelihood of being diagnosed with breast cancer in advanced stages for Black women. So these actually highlight, so for example, from the report, we do know that there is the likelihood of being diagnosed with advanced breast cancer. So when we talk about advanced breast cancer, that's stage 3 or stage 4. So that likelihood is higher for Black women. And that was a grueling report. It's something that when you read is very chilling. And I think that it's high time. We always have these sort of conversations or we see these reports, but it's important that we talk about it. Because when we don't talk about it, then we don't know whether what we are doing now is actually working. So it's important that we are having some of these conversations and brings these things to the awareness of people who are in positions to do something about these inequalities.
And dare I ask the question, why is it so bad? I mean, these are not small statistics you're talking about. A Black woman is 4 times more likely to die during or around childbirth. Why?
Well, there are a lot of reasons underpinning that. And one of the keys is when we listen to women's stories, for example, we did have a PPI to understand Black women's needs. One of the things that they keep saying is that they are not being listened to. When people are not being listened to, these are some of the barriers or the challenges that could then lead on to missed opportunities for care. And so when this happens, then we tend to see some of these reports we see. So that's what I would say. And then we can definitely highlight some of the challenges as we go along. And then I can put some of these later on in the chat at some point. But one of the key things that was raised was the fact that women felt they are not being listened to. And if we are not listening to women, then there is that opportunity to miss care. One other factor was whether when women do have a pre-existing condition, and then if that pre-existing condition is not managed, so I'm talking about women who experience maternity inequalities. One of the factors that was also mentioned was the fact that some of these women might have a pre-existing condition. And so if this pre-existing condition is not managed, then there is also that opportunity of or that missed opportunity for care that would ensure that there is an improvement in outcomes for these women.
So you're suggesting that they experience inequality in a pre-existing condition, so they're already being treated differently, maybe underserved in that treatment, and then when they go on to have a childbirth experience, that sort of just extrapolates.
Absolutely. So it's more like it's multiple. So the woman would have a pre-existing, let's say, might be having diabetes, might be having a cardiovascular disease. So there might be pre-existing conditions that are not well managed.
Yeah.
And so there is that missed opportunity to manage that, and that might have an implication on the maternal care. So if I am pregnant and I have this pre-existing condition and it's not well managed, that might have an impact on my outcomes.
Yeah.
Yeah. I mean, I want to ask one thing, Linda. As you said when you were giving your introduction, also, like you are working for women in your Black community, and now you're sharing they have some precondition, and when they go for a pregnancy, and the problems still happen. And Marin question was very strong. They have more problem during the pregnancy. So, sitting in this position, do you think any changes happened since this program started, or since you started working? Because I've been hearing this from long time. And now through this podcast, definitely we would like to know, is there any solutions happened? Is your position has given any kind of satisfaction to your woman in your community, and the information has gone widely? So I would like to know that also, because we always talk about problems are there and the solution has been done or not.
So when we heard this embrace, or we saw this embrace report, it was in the news all over, which was very concerning. So my colleagues at BU, so there were four of us, Abigail and Vanora and Carol. We had what we call a public involvement workshop where we had this consultation with Black women essentially to identify their health priority needs. So when we had that discussion, one of the key points that the women raised was the fact that they feel that their voices were not being heard. So when we talked about these embrace reports and all that, that's one of the things that they said, that they feel that their voices are not being heard. And from that, when we heard that, or when I was introduced to the Dorset Women's Health Hub project, and I felt there was an opportunity there to facilitate improving access to care for women from marginalized communities. And so I felt, or we felt, that that was an opportunity to facilitate that. So we had some objectives that were set when we were part of the project. So one of our objectives was to map the uptake of services by women, so from different ethnic groups, different ages, the uptake of services. We wanted to see what was happening. And the other objective was to identify the barriers and facilitators in access to care. And another one, because the women had said that they felt they were not being listened to, and therefore they feel that the HCPs might benefit from some sort of training. So racial discrimination training, sort of. So again, this was also part of the objective that was set. And so we felt that, in essence, this would then improve the experiences of women when we, for example, we undertake that particular training, or this training is delivered as part of the project. And we also felt that when we are able to map the uptake of services, it will help us to know which areas that we need to work more on. So that was the objectives. Now, so within that, racial discrimination training was delivered and it was attended. I wouldn't say it was a lot of it's because of time, we do know, which is so precious. So the ACPs that did attend actually felt that prior to attending the program, 50% said they didn't feel they had little or no knowledge in identifying, for example, a cultural ally. So after the training, 100% felt that they felt good, or they felt able to be able to identify a cultural ally. This means that if they put this into practice, we hope this would then improve the experiences of women who would be assessing this care. So that is what I would say in that. We also, I know from the project, the findings from the surveys that were organized or that were distributed, it actually also fed into the content that was created within the Women's Health Hub resource. So this is what I would say. It's still very early on, so we can't really be sure of what the impact is at this stage.
No, thank you very much. I think you explained it very well, and I hope it will continue and women will get more support.
So we go back, circle back to my original question and come back to you, Lorraine, in terms of, we've talked a lot there about women's inequality from an ethnic or racial or religious background, but obviously minority shows its face in many other different ways, and you represent a different kind of angle on this. So what would you say why it was important that we had this work stream in this health programme at all?
I mean, the key reason it's important is that it is going to be saving lives. And that may sound rather dramatic, but actually it's not. I do some keynote speeches at events, and one I was at earlier this year, which is for the BASH, British Association for Sexual Health and HIV. It was their AGM, and I was at their conference, and I was talking about health inequalities facing disabled people. And in preparing for that, I uncovered a statistic that actually disabled people are the largest single minority group within the UK. I think I was looking at the stats for England particularly. And that was quite a shock to pretty much everybody at the conference. And what also seems to shock people is when I say that I am yet to be made aware of any GP practice in Dorset, but also in the entirety of the UK that has a hoist. At the celebration event for this Women's Health Programme initiative, I was speaking to a local GP who's part of a primary care network, which has 9 practices in it. And apparently there is only one adjustable examination couch, which is in the sort of the practice nurse's room in one of the GP practices. Every single other examination bench was one of those static ones. So when you look at people, not everybody recognises or would not identify as the fact that they have a disability. But when you think about particularly Dorset with its ageing population, and we're very popular with people who are getting on a bit in years. Can't believe I'm over 50 at this point, but we'll let that lie.
You don't look it, Lorraine.
Oh, thank you. I'll pay you later. So, for lots of reasons, people are unable to get up easily on one of those static benches. If you're looking at somebody like myself who is still on the radar for cervical screening, and, since I've been in Dorset, the first time I got invited to my cervical screening appointment, it took me 3 years from when I got that first invitation letter to actually achieving having my cervical screening test. A lot of that was ignorance on the part of a combination of health staff. So we had the first try, and I'm using air quotes for those that are listening, when I basically explained that I can't hold my legs. I have muscle problems. I can't hold my legs in the so-called, oh, just relax position of the froggy legs flown apart. And they're still trying to poke around, by the way, but it's very uncomfortable and didn't work the first time. So they're like, well, we'll have another go and we'll make sure we have a second person here to help you. So I had to recover from that first trial attempt because I have energy limiting conditions, which they don't see. All they know is they've got their appointment for the 20 minutes. They want you to turn up, which obviously I did, and be on time. And then you go off and they're like, oh, well, she can just make another appointment and come back. It can be weeks. Sometimes it can be months before I can go and do something like that again. So we had a second appointment there, which also failed. And I said it would be really helpful. All they need, right, for a lot of people is to have a set of leg supports or stirrups on the examination couch in the GP practice. And the amount of people that would help would be phenomenal. So if you have something like ME, fibromyalgia, MS, Parkinson's, anything that involves your muscle power, including if you have a spinal cord injury and you're not able to maintain that position, would make it accessible. So they referred me to a local cottage hospital because they're like, oh yeah, they'll have the leg supports. Went in, and it's like, there's no leg support. So we had another try, and unfortunately that wasn't very successful. Then it was like a gynecology consultant appointment where I was expecting, they do have the leg supports in a hospital situation, in gynae type related departments, which is fantastic. But it turned out that was like a little chat about stuff. And that was another time I went out and I came back, no screening appointment, with the added insult, I might add, that the consultant turned around to me and said, because I was trying to do double bubble of getting my coil replaced at the same time. And he's like, well, why are you thinking of getting a coil? And I said, I just thought I had a moment, right? And I thought, I can run over this guy in my wheelchair. I can be very grown up and mature and not punch him. And I said, for the same reason that any other woman of childbearing age who does not want to get pregnant would want an intrauterine device to stop getting pregnant. So then it's like, I'm recovering for that appointment. I have to go back then. So that's why it took 3 years. Now, in that time frame, the whole purpose of cervical screening is to detect early changes. So if there had been early changes that were then let to life for 3 years, possibly I could have developed more symptoms. There might have had to be an operation. It would have been much less traumatic in that situation to catch it early. But, I've spoken to hundreds, if not thousands of people, mostly women, about accessibility in both sexual health clinics and GP practices. And people have told me, like there was one lady who has a skin condition and she is deaf, and they took a biopsy from her cervix without actually telling her, because their head between legs, and they knew she was deaf because she'd had problems actually going into the clinic. And so can you imagine if you're there getting examined and the first thing you know about a sample is when you're being cut? It doesn't bear thinking about. But also, we're talking about women. When you hear that somebody has basically been told to keep their fingers crossed and let's hope there's nothing going wrong because their physicality has made it a little bit challenging for the medic to see what's going on in their body. I mean, would a man be told in a similar examination for a cancer, well, let's keep our fingers crossed? Is that really where we are in this day and age? So for all of those reasons, I get involved with initiatives like this Women's Health podcast because it's really important. And I know I'm not the only disabled woman in Dorset, but I swear to goodness, you'd think I was. This is like a call to action as well. It's like, if you've got a long-term health condition, for goodness sake, if you possibly can all lend your voice and get involved with this sort of initiative, because it's really important.
this is the health service, right? This is a health service. How is it going so wrong for people with a health condition to access healthcare? I mean, it just doesn't make any sense to me. I mean, Linda talked about what sounds to me overt racism in women not being listened to. It's bad enough just being a woman, but being a black woman, being a disabled woman, it's like you're sort of doubly not listened to. Would you say that that's the case?
Yeah. And there is a lot of intersectionality. So it's like for some women, it will be a double, triple whammy situation. And I think I can echo what Linda was saying about the not being listened to. I've got to a stage in life where I've given up being quiet about things. I've stepped into my power. I'm not waiting around anymore for somebody else to do something. I'm like, hang on one sweet second here.
Why has it taken so long for someone like you to speak up?
There have been others that have spoken up, and it's something that I am in the process of looking into, is how we can combine our voices. But with the lived experience that I have with health issues, everything is a battle. Being a woman in business is an extra battle with disability, because quite often events where you would normally be attending to get the word out about your business or product or whatever, you can't even get in the room, right? So at that celebration event, you guys were fantastic because you made sure it was a fully wheelchair accessible venue with a wheelchair accessible loo, because, women need to go to the loo, just like men. Even though we might be a wheelchair user, we still need to go to the loo. So going to a day-long event or whatever where there isn't an accessible loo, that means you don't go.
I won't say I'm sorry, but I am a little angry actually after listening your story. And I feel like if I see from the financial point of view also, if they are giving you so many appointments, that is also costing them every hour to GP or receptionist, logistics, the GP, everything. Why can't they just think about to having the right equipment and logistics in one place, which might cost them less than what 3 years cost must be? So if they will put some right people in the right place for fundamental logistically, that might be a question can be answered. Like, this is the health sector and they need to be serious about it. And having said that, your example actually scares me. And I think this podcast might be a very big eye opener for many people like me. Just want to add, I have a daughter who's 17 now who has a special need. And one of her special needs is her sensory issue. And once she will be going for any such test, I don't know how we're going to manage it, because if they're doing a cervical test, which they will put things on her vagina, wherein your favorite word is there. So how she will manage, because she has a sensory issue. Even she scratch, she cry. She see blood, she cry. So do the health system has a setup for women or girls like them?
There are little pockets, little jewels dotted around the UK and obviously within Dorset as well. So for somebody like your daughter who's got sensory issues, and I am autistic myself, so I have some understanding of what that can be like. There are some resources to do with that on like a fully subtitled or BSL sign language interpreted little videos on good practice, and to talk you through and walk you through what is actually going to happen at a screening test. So one of the things that I do is when I find a little gem like that, I publicize it as much as possible. It goes on my list of gems. So then when somebody rings me and says, I'm worried about this procedure, have you got any resources? I can go, yes. And then I send them about 5 different website links. But it's the staff themselves having the time and the intention and wish to find out more, to be as accessible as possible. Sometimes that's missing. So attitude goes a long way.
Yeah, absolutely.
We recorded a podcast recently about gynecology, and we were lucky to have Daniel Webster with us, who is the clinical director for obstetrics and gynecology for University Hospitals Dorset. And he was talking about an initiative which has a very unpleasant sounding name of GIRFT, which apparently stands for Get It Right First Time, GIRFT, which is, I believe, a national program which is trying, Lorraine, to get it, well, as it says on the tin, get it right first time, so that women like you don't, and I think it is a very specifically women's health program. And he mentioned that. And it's a shame we can't go back and kind of bring him back into this conversation. But to me, what it sounds like is the importance of having voices like yours and yours, Linda, on programs like this thing that he's now working on, Get It Right First Time, so that the clinicians really understand what it's like when you don't get it right the first time. And not only the trauma, as you described, Lorraine, to the patient, to you, you're a human being, but to the system, the expense of having not got it right first time with you. I mean, heaven forbid had anything terrible happened as a result of you waiting such a long time. But even just the cost of all the appointments, as Angela has pointed out, it's just crazy, isn't it?
And part of that being in a semi-rural and rural community in Dorset as well is things like having an accessible mobile breast screening unit, which I don't believe there is at the moment.
No.
I'm happy to be corrected on that one, though.
I mean, we could spend this whole podcast talking about, our frustrations around these things. But the point, if I could bring us back to this women's health program that we were involved in, was to try and tackle some of this stuff. And it was all of the things we've discussed was the reason why we made sure that minority and marginalised voices was a very specific work stream in and of itself within this program. And Linda, you've already mentioned some of the work that you did in that work stream was about training. And presumably the training was because you wanted to address this issue of women not being listened to. And was the training about specifically just women from ethnic minorities, or was it about inequality generally? And what did the training involve? And who did you give it to?
That's a very important question. Can't really remember the name of the person we gave it to provide the training on top of my head. But it would have been, as you said, because when you talk about women from marginalized groups, it's not just about racial marginalization, and it's from a lot of women from many communities that do experience this. And for some women, as Lorraine said, they've got intersectionalities as well. So, which means there are added layers for some of these women. Unfortunately, the training was geared towards racial discrimination. So that was what was about the training for healthcare professionals to develop that understanding and awareness of how racial discrimination can impact on the experiences of patients or service users, women that want to access care services. So it was also born as a result of, as I said, the PPI workshop that we did. So this is one of the things that did come up. So when this Women's Health Hub project was introduced to me, and because I've also worked with Vanora, as I said, then during the discussion around what work streams we might want to also focus on as part of the Women's Health Project, this, in terms of the racial discrimination training for ACPs, was included as part of our objectives. So there was limited time, as we know from the inception of, even when I was introduced to it, and up until when the project had to then be finalized, it was limited time. But so ongoing, these are some of the things that we need to look at. Women from other marginalized groups, what sort of training can we do for ACPs to improve these women's experiences as well? So it's, if perhaps maybe as we go along, you might want to ask what are some of the things that we think we need to do more for this project. And this is one thing that I was going to say. Definitely, because we couldn't, within the time frame that we were working on the project, we couldn't address all the training needs regarding women from other marginalized communities.
I mean, do you think training would help, Lorraine? Is that one of the answers, do you think?
I mean, there has been a slight shift, which I'm happy to report. I do a lot of stealth infiltration of various networks in Dorset. And at one recent one, I made a connection with somebody from Mid Dorset Primary Care Network. So I'm really happy to say that they were also shocked at some of the stuff that I was saying and welcomed me. And we're going to be doing a little bit of co-working to get this message out there to educate GP practices and any health clinics really on what they need to be thinking of and what a difference that it can make. So, there are, generally speaking, the NHS is good people. Do you know what I mean? I'm not an NHS basher.
Certainly would be our experience of working on this program. I would wholeheartedly agree with you about that.
Yeah. They have literally saved my life in the past. So, it's not bashing. It's the fact that I want everybody in my particular sphere, I'm dealing with people that have got disabilities and stuff. I want every woman with a disability and long-term health condition to have the same level of access to good health and life that any other woman has. And it is a bit of enlightened self-interest because, if I can help make things better for everyone, I'm making things better for me. So, I'm not like totally altruistic or anything. But yeah, that's what I would like to see. And it's finding the gems who at that moment in time are in a position where they can take up the baton and help us get the improvements. That's really crucial, I think.
I totally agree with you. And I hope the training, workshops, more activities can be, provide for local people.
Yeah. I mean, something that happened recently, I was having a health appointment for a particular reason, and the screensaver, this was in, I think it was Poole Hospital, the screensaver on the doctor's screen was actually promoting the Oliver McGowan mandatory training. And I'm one of the co-trainers for that particular scheme. And Oliver was a young man who had a mild learning disability and was also autistic. And very sadly, the people involved in his healthcare did not listen to him or his family. And he was re-prescribed some antipsychotic drugs, which he shouldn't have been prescribed. And he'd already had a bad reaction to previously. And very sadly, he died as a result of that. And his family did a lot of campaigning to get it into UK law that this mandatory training had to happen. So for me, to be in that position as I'm a disabled person with autism who also does training and is involved in women's health, to be in that appointment and know that the NHS in Dorset has invested time and money in putting on that training is really, really good news because it's not happening everywhere, even though it should be. So there are some really good bits and pieces here and there.
Well, I mean, I think this programme itself is an example of how the NHS in Dorset, I mean, everyone that we worked with was so passionate about improving these things for women of all the subjects we've talked about. But this one very much included in that. There are people, Linda, aren't there, who really do want to tackle this problems, which sort of leads me to my last question, really, which is, what needs to happen next? I mean, what are you both working on that's still championing this cause? And, what's the next priority? What's the big thing that we need to address coming up?
So what I'm doing at the moment is I'm updating my ebook that I wrote a few years ago, which is aimed at GP practices and such sexual health clinics. But I'm going to be getting more of like first person case studies included in that book. So that's a project that I'm doing at the moment. But also I'm in the process of booking in a set of drop-in clinics across Dorset where I'll be inviting anybody who has an interest or lived experience with disability and long-term health conditions to actually invigorate them and say, look, this work needs doing. Have you got any capacity? This is what you can do. For those of you who can't actually see what we're doing, because this is like an audio thing, I'm actually joining this conversation from my bed. I do most of my work from my bed because I can't sit or stand for any length of time or I will pass out. So I have my computer screen suspended above my head. And that means that I can work and I can do a lot of disability activism. And so, that's the important thing, is to get the message out there. So there's two very clear things that I'm doing. One is make sure that I do the updated book, because that's going to be a lot more widespread this time round, and then do the involvement consultation session thingies around Dorset.
Brilliant. Always the activist, Lorraine. Amazing. Linda, what's next for you?
I think that one of the things that, as Lorraine was talking, that struck me was the fact that we need to work in close partnership with the people whom we are trying to improve the assets for.
Yeah.
So we know that the way the world is moving now, everything is going digital. Now, how ready are the community that are already being marginalized? How ready have they been prepared to embrace this? So I think we need to work closely with them so that it doesn't become an added barrier. So we need to work closely with them to understand what would work best for them as we enter into a digital care access age. Because this is what I'm seeing. This is when you read anything, this is what is happening. Maybe if not, I know it's ongoing, but in maybe 3, 4, 5 years to come, how ready have we prepared these communities, these women who are already being marginalized, to improve access to the digital care space? And we can only do that by working with them.
How do you do that, Linda? I mean, I know you're very experienced in this field, so maybe you can help us understand.
So we need to go to the communities. It's interesting because I can share my experience as a Black woman and working with Black people. So sorry, Lorraine, if I'm not able to address other women from other backgrounds. Because when we talk to the women, what they say is that researchers, those that are in position to enact changes, they need to come to where we are. So when you say, how can this work? Where are these women? Where can we find them? Who are the bridge builders? Who do these people trust? If there are issues with trust, that is also impeding access to care services. Who do these people trust? How can we embrace and involve all of them to understand what it is that would work for them? If we are bringing something up, these people are already marginalized. So we need to think about how it's going to work for them. We can only do that by working closely with them. We need to go to where they are, listen to their concerns, and work with them, take them on board. So it's good that we have this website, which is a first step. But we need to have some sort of ongoing monitoring. And we do that by listening to what the women are saying and incorporating that as part of feedback to improve on whatever the structures that we do have in place and any other service that we think that we are digitalizing it. Because that's what I'm seeing, that this is what is going forward now as we see.
I think I echo with Linda, and I also believe in this, Marine. I mean, I think this program, and especially this podcast, which we are recording now, will be definitely one of the channel where people can connect and see what the support is available. But having said that, maybe extension, maybe you get funding, Marine, or maybe one a day. But I think we discuss some kind of networking where we can call all the community leaders from different diverse community, and then we can share this podcast information, or more people we can invite, and then there can be a bridge and they know this is the information available, and each leader might get a opportunity to get trained, maybe if there's any possibility or any funding available, and then they can pass the information. Because I can say from Indian community, from digital point of view, the population of Indian community in Dorset are very working class people. I have done the survey. So most of the people are either working in JP Morgan, Pool Hospital, or in Barclays. So they are very digitalized people. Like they know to access having on the AI or digital world. So passing the information to them will be easier. But then there will be some of the minority community, they don't have access of digital world yet. Some old home people, and Marine, I was just thinking in this very fascinating word come across to me when I was looking one picture. One disabled lady was holding a crash, and there was a phrase, she doesn't use smartphone. So the word comes to my mind is she's also disabled. She's social media disabled also, because she doesn't know how to use smartphone. So how she will get access of health information, which is going towards app and everything. So I think we really need to find right people who can definitely become a bridge and give the information to all the diverse community and the women who are into minority actually.
I mean, I think that answers the question really nicely in terms of, my question was, what's next? It sounds to me like what needs to be next is that we need a network of trusted people who, I kind of hate generalizing like this, like minority communities trust, in order that whatever information we have that could reduce their inequality of experience and lengthen their lives, their healthy lives, and give them equal health opportunity, that we can use that somehow. That seems to be the next step in terms of dealing with a very big and very entrenched problem in our society.
The good news is that there are some building blocks to that already in Dorset.
Yes.
The Community Action Network Dorset have got a Trusted Voices project, for want of a better expression, and that can help. And they've also recently, I can't remember what the buzzword for it is, but basically for people that are ethnically diverse minorities in the area, where they're taking actually control and taking the lead on making connections and pushing forward projects that mean something to them. So, similar to the NHS, there is some good work going on. It's just getting the word out in a variety of ways so that everybody has a chance to know about it.
Lorraine, you said it's very important to have a trust. And then Lauren did mention there are some people now in NHS who we can say champion or a voiceover people who can connect people. But I feel like with my experience, especially during the COVID time, it might change, but still for health reason, people have their opinion about NHS. And if we have some particular people who they, one diverse community or any minority community or any woman group, anyone who they trust, they believe that person more often what NHS is providing. So if it is going, like I can example you, Lauren, some of the people might thinking what Lauren is saying is right, what my GP is saying is not right. So I think we need people like that who can be a spokesperson and they can say, yes, what information is coming from NHS, is it right, and it will help you. So I think this is also one of the thing I feel, Maureen, we need to promote, like having a people or speaker from minority community or women who can vouch for NHS.
The Dorset Race Equality Council used to have community champions. Do you know if they still do?
Yeah, they still do.
Okay.
I'm a member. I'm a board kind of a trust member with them. Yes.
You are one of said community champions. Lorraine, the Community Action Network, Trusted Voices, does that include people from other minorities, not just ethnic, racial minorities? Does it include disabled people with disabilities or older people, younger people?
Basically, anybody who has been involved in sort of community work or campaigning or have lived experience. So it's open to anybody. And then they've recently done this initiative, which is supporting people that are from minority ethnic groups, etc. So, and that's actually quite a good central repository for information. And I think there's also Dorset Community Action, which covers the rest of Dorset. So between even those two organisations, people can get a lot of information. Yeah.
I mean, it's a vast subject, isn't it? I feel like we could/should do a podcast just on this subject, the issues faced by women from minority backgrounds. So perhaps we'll hold that thought also.
Yeah, that would be fantastic. And it's also keeping the information there for the future. So what I love about podcasts and interviews and the like, and even blogs actually, is that information can sit there and somebody maybe in 8 years' time, 10 years' time will do a search and they'll have a particular question and then they will come across this little gem, which will hopefully help them, point them in the right direction.
Yeah, it's such an important subject. Which just leads us to say thank you both for being here today, giving up your time. I know you're both very busy people. It's been a really interesting conversation and can't wait to get it out there into the world for other people to see what goes on behind the scenes with projects like this and to, really what's important for me is to understand that so many people are trying so hard to try and tackle some of these problems. I think that's the key message.
And I think a podcast like this, where they're sharing their own experience, like Lorraine and Linda, that really enhance and connect the right people to the right time. So thank you to both of you. Really enjoyed talking to you.
You're welcome. It's been a blast.
Wow, what an amazing discussion, Marin. What do you say? I'm emotional.
I'm not surprised. That was such a shocking but inspiring conversation to be part of, wasn't it? And some of those things that Lorraine was talking about is almost unbelievable.
Absolutely. And I think the thing which is still in my mind is about how difficult to get the equipment in the right time, especially for the disabled woman. And the way she has explained her story, I hope that can give hope. She is doing things in the right way, and she's helping other women what she has gone through.
I know she is. She's a very passionate advocate. But it's also reassuring, I guess, to hear all the amazing things, the research and stuff that Linda's involved with. And I mean, does it give you hope, Anjali? Does it give you hope that things are being addressed and that things will improve?
See, if you think about what Lorraine, she was saying, there was nothing good years back. Like if you talk the 2 decades ago, the time, there was nothing. But now some things are there to address her problem. I think one day it will be available for everyone. So that hope is there. Things are not getting there exactly what we're expecting, but the things are going ahead.
We're going in the right direction, I guess
yes,
you can say.
We are going in the right direction right now.
Well, and I know that you and I will continue to champion this cause.
Absolutely.
People can look to you in particular as a real champion. So what a brilliant episode. Great one today, Angie. It's great to see you again.
Want to add something before you say final bye?
Yes, go.
I'm 100% sure when this episode will be shared with everyone, with live for everyone, I think there's going to be a good hit in our minority and ethnic minority community, because definitely that's a need, that's a voice they're looking for. And I'm glad I can be part of that thing.
Well, I'm just really pleased to hear you say that.
Thank you.
I shall go away from today's episode with a warm glow and a sense of hope. Fantastic. So make sure you listen and subscribe in all the usual places. And don't forget to check out the Women's Health website, and we'll put the link to that in the show notes, along with all the other relevant resources talked about today. You can find links there. And we look forward to next time, episode 5, when we're talking about women and mental health.
Goodbye, everyone, and keep listening.